area with unstable at night, it's really difficult to get to those places. So you get that second delay. So delay in seeking care, delay in reaching care, and the last one is delay in receiving adequate care. And delay in receiving adequate care is like, you go to the health center, do they have the drugs that you need? You go to the health center, do they have a doctor? Do they have a nurse? Do they have electricity? Do they have antiseptic? Do they wash their hands? Like these are all elements. I think we disproportionately focus on that third side, the receiving adequate care. I think it's really important, but you can build amazing hospitals, but if no one's going to them and no one can reach them, it really doesn't matter if you have an amazing hospital. You get what I'm saying? Mental health, I think, is actually on that stage one. People are not seeking care. There's a level of stigma. There's a level of identity crisis with being in these areas of women that's given birth and they have to like take on all the familial roles. And if they need help, then they're actually just not being an optimal wife or a woman or a mother or whatever. So I think delay in seeking care is really important. But with urban-rural divide, I would really think about that second delay. In rural areas, it's hard to reach care. And then in urban areas, I would say, people, there's more education, there's more word of mouth. It's probably easier to get to health centers. And so you want to focus a little bit more on that third side, which is like, what do the health centers have? How can we help them, reduce their costs so that they can support patients more? And then in urban areas, the mental health situation is going to be really different than in rural areas. And mental health is super stigmatized. It's stigmatized in North America. So you can imagine in other places where they haven't had the same freedom of education, the same, opportunities, that it's going to be even more stigmatized. So I think you're onto something really, really great. So to summarize, that's the 3 delay model. It's my favorite. I think postpartum is really important and often really neglected in that side of things. This is a kind of an interesting angle, which is looking at menopausal women, so the grandmothers, because they actually play a huge role in maternal health outcomes in a lot of these communities, because they're like the elders and the wise ones. And if you can actually support them in supporting other women, specifically through things like traditional birth attendants. I'm not sure if you guys have talked about that, but traditional birth attendants are usually grandmothers in the community, and they've kind of been trained through an apprentice model, and they don't have formal medical education, but often they support pregnancies and they sometimes even deliver labor. In Nigeria, they support 80% of women delivering babies. So they're also a really interesting angle to go through, but they have their own mental health struggles as elders in the community. So there's a lot there. I hope that answers, but if you have any follow-ups, feel free to ask.
You actually answered a lot of questions like really well, even questions that I didn't know I had until you were talking. So thank you so much.
You're so welcome. Here, I'll drop my email. So if you literally have like anything else, I'm happy to help. I think that's a super important problem that not a lot of people are working on.
I guess.
Does anyone else have any questions?
Yeah, I would like for you to tell us a little bit about your experience in Nigeria, the work that you did, how you used digital technology to make that happen. I mean, the impact that it made, because I think that their case study is around using digital tools, to improve maternal health. So I think we would love to hear some of your experiences using these tools to improve maternal health in the rural communities, or your work in Nigeria or maybe Burundi.
Yeah, that's a great question. I started my work in Nigeria as someone who went on Our World in Data, which is a great website, and they have data on maternal mortality, on mental health, on all health outcomes. And that's where I started. And I got very, very frustrated at the numbers, specifically realizing that if we scale, we would have and not 350,000 maternal deaths a year. So then what I did is I did what I would call a root cause analysis. I tried to understand all the different diseases which disproportionately affect maternal health, all the solutions we have, and how those come together. And I just started interviewing people in Nigeria, because Nigeria has one of the highest maternal health burdens in the world. And from there, I got into a partnership with a charity and the local government. And we created a system to distribute misoprostol, which is a very much approved intervention. It's been approved and recommended by the World Gynecological Association since 2006. It's been on the WHO list of essential medicines since 2011. It's been on countries' list of essential medicines like Mozambique and Nigeria, also in the early 2010s. So it's this very approved intervention that hasn't been scaled in any country in the world. So what we did is for 2 years, we basically tried to convince the government to invest into this intervention. And we also recommended SMS technology to help track these drugs and support people in rural and hard to reach communities. So that was like my side was I did all the reading. If people didn't want to read the articles and the PhD theses, and I was like, okay, fine, I'll read them. I'll make you a nice presentation that'll summarize the key points. So that was my role. And it was super, super amazing. The teams were great. People had their hearts in the right place. And in the end, it came to the point where I was like, this is yours. Everything that I made, all the intellectual property, please take it. Just take it. This is like way more important than putting my name on it. So that's what we did. We gave it to we donated everything to them. And they've been using that to inform their policy and hopefully push some more papers and make some moves, because it's a very taboo topic. Misoprostol is an amazing intervention, but because of its linkages as an ingredient to abortifacient pills, it becomes a very touchy subject, especially in places with restrictive abortion laws. Now, we weren't even recommending it for abortion specifically. I mean, it's a very good intervention for that too, given that at the time, 11% of maternal deaths had to do with unsafe abortion. So there's a very, very real need, but we focused on postpartum hemorrhaging, bleeding after birth, because that targeted 30 to 60% of deaths, depending on which geographical region you're looking at, and it's a little bit less taboo. And you need to start somewhere, you know? Most recently, I kind of pivoted from that to work more on the on-ground implementation side. So I work for a company called Madiro. They're fantastic, and they invest in public health technologies. And they have a lab in Burundi, or they have a clinic that they've sponsored in Burundi that they're using to pilot things like electronic health records, or new forms of oxygen delivery, or new forms of internal communication. How do you reduce burdens and data collection, that kind of thing. They're building a clinic in Burundi. Burundi is one of the, I think, the poorest right now by GDP per capita in the region, and it's one of the poorest countries in the world. And their healthcare system is notoriously very rural or non-existent. So this summer, I did some field work at the clinic in Burundi. I did what's called a quality improvement assessment, so using the WHO's tools. And here's a pro tip. The WHO has this toolkit called the Quality Toolkit. So literally, if you work up World Health Organization Quality Toolkit, you can browse every single document that they've made on public health and quality improvement. So you can go WHO Quality Toolkit, and there's like a search bar, and you can look up maternal health, or there's even a mental health, or there's even, you know, infant and newborn health, or kangaroo care, which is like more newborn, but I mean, all of it's intertied. You can't really talk about maternal health without also talking about newborn and infant mortality kind of thing. So very important, really great toolkit. And I was the one to analyze all that data. And I supported translation to French, because Burundi is a French country. And we basically tried to make these very bureaucratic tools more accessible on that scale in order to prepare this clinic to become fully digitized. There's not enough doctors. There will not be enough doctors in the African continent. So it's super important to take on digital technologies, but you can't just slap digital to the solution. One of the reasons is that there's no infrastructure. If you don't have cell phone lines, you can make a great cell phone calling system. It doesn't matter because you don't have cell phone lines. Or, for example, the region we were at didn't have good network. So I could build an app and it doesn't matter because there's no network. You can't use the app. So one of the things that we worked on is preparing these clinics, which have low capacity, staff are overworked. They do not have digital infrastructure, and their training isn't digital in nature. And so it will require a lot of systemic and intellectual change to be like, hey, by the way, we have this SMS system and it's really great. That'll require them to change their entire workflow. So the quality improvement project that I did, it was acted as a foundation for digital, and we created stepping stones. So next up, we're doing an electronic health record system. But first, we want to make sure that someone is the data collection officer at the clinic. So we created a role where people once a month meet and they talk about a couple of key performance indicators. So we suggested looking at how many deaths and what do deaths come from, and then we gave them the WHO death review form, which is part of the toolkit, the quality improvement toolkit. And we said, can you also keep track of your inpatients and outpatients so you can practice, counting data? And so later on, as they developed the first habit of data collection, let's make that easier with SMS. But instead of having to have them change their behavior going from paper-based to SMS right away, we wanted to have them practice a new behavior, which is data collection, with the system they're already familiar with, so we can change one behavior and then the next one with digital, if that makes sense. So I would try to break down processes as much as you can, because it's easier for people to change one thing at a time than to change 5 things at a time and try to keep track of that. So even though we all probably agree that doing data collection on your phone is much faster and more convenient than handwriting everything. But from a behavioral change perspective, it's actually better to go for the inefficient handwriting, because you change the behavior from not collecting data to collecting data in a way that you're comfortable, and then eventually collecting data in a way that's more efficient. If you can kind of see that step process. That's the work that I'm doing in Burundi now. And I now work for the organization. I also support other public health initiatives. So right now I'm working on two big projects. One is a South African digital assistant for adolescent girls who are at risk of HIV, motherhood, or both. And what we are doing there is we're piloting a tool that goes through the health community workers, which is another tip that I have for digital. In all the projects that I've worked on, the commonalities, we never went to the consumers for a couple of reasons. One, cell phone penetration. I mean, Ghana is different. Ghana has more cell phones than people, so you do have to look at your countries. But the countries that I worked in, the cell phone penetration is not there. There's a little bit of privacy concern. So young girls who are 10 to 14 probably don't have their own cell phones, or if they use their parents' cell phones, they might not want to talk about these taboo topics, etc. And the other thing is you don't know where these people live. And so if you're relying on a consumer-based cell phone or mobile or digital application, you don't know if they have network. You don't know who is looking over if they're in a domestic violence situation. You don't want them to have an app. It's like track your period, or don't get pregnant, or avoid HIV/AIDS. These are very taboo topics. And so you have to do them a little bit easier. So from my perspective, always it's been through the healthcare workers, because you can control that a little bit more. And if you think about it, when you go through one healthcare worker, for example, the South African project that we're working on, you go through one healthcare worker and you can impact 50 adolescents versus having to get 50 adolescents on an app that eventually go back to that healthcare worker. So try to think about if there's ways within the healthcare system that you can use digital as a stepping stone too. So you don't have to, just expect everyone to be on their phones, etc. I would try to think about it like that. The other project I'm working on is an infrastructure project related to oxygen delivery in Burundi. And for that, we're also thinking about digital because it's logistics. It's figuring out, we have different hospitals and clinics and they don't have access to oxygen. How do you connect them? That's really hard to do without digital. We're not going to be sending letters every time that someone has a lack of oxygen. So that one, we're also thinking about digital and thinking about SMS systems. And you know what? We're even thinking about mapping, because how are you going to send an ambulance in rural communities that don't even have road maps? There's no road signs. Everything's by phone. And so a very underrated part of digital innovation in public health is actually not building the app to the SMS systems, but actually building the infrastructure, thinking about cell phone lines, thinking about network, thinking about electricity. We don't think about, that's not really digital, but it is technology. If you don't have electricity, you're not going to be able to power any of these things. If you don't have a backup generator and your clinic is relying on a data collection system. So for example, we're piloting an electronic health record system, and we can't do that until we have a backup system, because the problem becomes, what if all the data falls, what if the electricity runs out and people are completely relying on this digital system? There needs to be a backup. We can't lose patient data. We can't lose, what we're working on. And we might have to, if the data is really, digital is really unpredictable in these regions, so you always have to have a backup plan. So backup generator, paper-based system, et cetera. So you can't just ignore that. And that's what we're learning a lot on the ground too. But the point I was trying to get at earlier is one of the biggest cases of digital is logistics management. So pharma, that was a big thing we did in Nigeria, is we needed to manage the drug and do the supply demand predicting. That's really hard, especially an intervention that hasn't been scaled yet, because you don't know where will people go the most, because we're putting it in pharmacies, we're putting it in medical vendors, we're putting it in hospitals, in clinics. And so we estimated where people would go, but after, we need data to know who's buying it from where. And if one place is running low, but another place has a surplus, let's move those drugs. Let's make sure we don't have expired drugs. You know what I mean? So there's a logistics management portion, but any logistics management is dependent on road infrastructure, which is dependent on mapping to some extent too, GPS systems. Burundi's a very unmapped country. I'm not exactly sure how Ghana is. Nigeria, northern Nigeria was also pretty unmapped in Jigawa and Kano State. So we had to think a lot about how to pilot those kind of mapping initiatives. So that's another angle for digital that I would recommend. But otherwise, I feel like I just talked for so much, so I don't want to too much. But I hope maybe there are some key insights there.
Definitely. Thank you so much for sharing.
Yeah.
Does anyone have any question? because I just don't want to take over the whole program.
You're so good, don't worry. Or you can even tell me what you're researching or looking into, and if there's something that like comes up in my brain, I can maybe point you into a resource or a framework or something like that. Okay, well, I can just list a few off the top of my head then. I already mentioned WHO Quality Toolkit. That's a really great one. Our World in Data is also really great, especially as you're building a case and you want to support your ideas with numbers and evidence. I would really recommend looking at Google Maps, frankly, like look at the region you are in. And one thing that I've done is I've literally like mapped all the pharmacies, all the markets, all the things that exist that you can start thinking about how to tie healthcare into people's lives. I would try to watch documentaries or videos. Like UNFPA has really great videos. They have great projects happening all around the world. And even if you're focused on Eastern Ghana, there's similar context. So if you can learn about a case study or technology happening in another place and consider scaling that, I think that's really impactful. For example, there's a company in Ghana called M Pharma. I don't know, are you connected with them? Yeah, they're really great. And when I was doing my work in Nigeria, I was constantly bringing them up because I think it's such a great example of healthcare innovation, using digital, using everything. So I think that they're a phenomenal case study, but I'm sure across the continent, there are some really interesting people contributing to this problem in a meaningful way. So if you can start to kind of see, you don't have to be locked into Ghana. You can look at what's happening in Sierra Leone, what's happening in Uganda, what's happening in Kenya, and is there anything you can learn from? And now just be mindful and cognizant of the context. Like you might be looking at Mombasa or Nairobi in Kenya, which are very urban areas, but they might have really cool initiatives. They might not totally apply to rural Ghana, but what can you learn from that? I think that's super important.
Yeah, definitely. That is very, very helpful, Alvid. Yeah, thank you so much for sharing. I guess another question that I did have is when you were sort of rolling out this whole digital tools in the like northern part of Nigeria, what were some challenges? I mean, apart from the infrastructure challenges, I mean, how did the people accept the technology? Because it's one thing to have all the infrastructures, and as you mentioned, there is that delay in seeking care. And if people have the belief that, oh, it's good to give birth at home, there's no way they're going to seek care. And so even with that, I mean, I don't know if you did any work regarding like how these people that give birth get access to vaccinations or immunizations and all that stuff. Like, what are some challenges individually or like the community members? How did they accept the technology?
We went through the traditional birth attendants, which I think was a really key node because they have so much trust in the community, so much trust with pregnancy. And because we donated everything, it was really important to us that it wasn't me and a couple of other people from the West just implementing technologies and putting it onto people. So that is really in the hands of the government. And to some extent, there's the political willpower is a very big challenge. Getting people on board with these things is a really big challenge because there's legacy in these communities. There is traditions and conventions like what it means to be a strong woman, and that is a huge barrier. The advice that I would give is go through the trusted nodes as trusted as you can get. If you're working in a community in Nigeria, we went through the imams as well because it's a Muslim area, and it's super important to the people on ground specifically. I was just following their guidance. It was very important to them to go through the religious leaders of the community, even if they might be opposed, because these are the people who, they're not doctors, they're not nurses, but they support people's daily decision making, and healthcare is kind of more at the mercy of the daily decisions that people make rather than what clinics or drugs that people have access to. Healthcare and what it means to be healthy is also in the food that you eat. It's in the conversations that you have. It's learning that someone got vaccinated and it was good rather than someone got vaccinated and it was bad. I didn't specifically work on the vaccine side, but there's been some interesting initiatives that I've heard about. One of them is having a monthly vaccination day. And I mean, as much as as free as you can make it so that people, and it's great for a couple of reasons. If you don't have cold chain supply, so if you don't have refrigerators, you can't vaccinate everyone every day. If you don't have refrigerators, that's kind of a deal breaker for vaccines. So what a lot of organizations have done is they've fractionally distributed vaccines. So they say, this clinic has it on this day of the month, or maybe twice a month. This one has another, so you don't have to buy as many fridges. And it also encourages the community to not procrastinate. Because if there's only one day a month, they can get their child. If there's only one day in a month that they can get their child or themselves vaccinated, then they're like more keen on going that day. Sorry, I just saw someone. So actually, I think that's a really interesting strategy I think it's a really interesting strategy to get people on board with, for example, childhood vaccines. It's like, okay, we're going to go this day, and it becomes a community event, or having things like food or via moms or these like trusted members of the community there is a really big game changer. So I think it's a really great initiative in vaccine cold storage supply. Another one I would say is if you can do more in one day, that's better. Another thing is doing any sort of like community event. So in some of the clinics that I saw in Burundi that I think were doing really great is they had this huge poster that was basically a checklist for parents on the government vaccines that were all free. So if you have free vaccination programs, that's really great. In Burundi, there's free vaccination programs, so their vaccine rates are actually really phenomenal, even though a lot of their subsequent health outcomes aren't. They've really put an emphasis on childhood vaccination, and that's really great. But that, I would say their strategy is pretty simple: free vaccine for everyone, and it's really clear what vaccines they need at what time. And yeah, so that's what I would say for vaccines.
Awesome. Thank you so much for sharing.
You're so
Definitely,
welcome.
yeah. I guess it's very important to really identify the different stakeholders that are very influential or have the trust before being able to even implement any sort of strategies or ideas or solutions. So thank you so much for sharing. Does
You're so
anyone
welcome.
have any question?
Go for it, Ella.
Hi, our group was talking a little bit about using information centers within the villages to distribute information. Can you talk about how we can do this? Like any experience you have with it?
When you say information centers, can you just specify what you mean by that?
One of my teammates from Ghana was talking about how some of these villages will have places to distribute information where you can go, like a community center almost.
Okay, that's really cool. If those exist, that's a great launching point. What we did in Nigeria is we focused on the mosques. We focused on what's called PPMVs. They're proprietary medical vendors. They're these like very small stands that will have kind of like commodities of medication, pharmacies. And even in Burundi, there's something really similar because there's pharmacies in every single corner. So I would say go to the places that have the most volume of people, and it doesn't have to be people seeking healthcare. So if you go to the market, or if you go to the religious centers, or if there's community centers are frequented, that's really great. One of the things that I noticed in Burundi is that sports is a huge thing. Now, I'm not sure what it's like in Ghana, but that's a really interesting strategy to be like, let's send people to sports games, but within those communities also share information at those sports games and make it accessible. That's something that I would say is really difficult for when you use WHO or UN material. It's very technical. So if you want to meet people where they're going to, you also want to meet them in the language. So you don't want to go to a mosque in your place of worship and have this like huge documentation on to get vaccinated, or the importance of giving birth at a facility, or the risk of infection, right? Like you want to have something a little bit more sensitive. So that would really be my advice, is try to meet people where they're at and where there's high volumes, and try to match the tone of the information you're sharing. Now, one of the things to be mindful of is that sometimes people already have the information, and sometimes they just don't want to act on it. And that is a very different problem. So for example, if they know that going to a health facility, actually I'll just give you a concrete one. In Burundi, there's a lot of malaria. And people know that if their child is low birth weight or really small, or like not sucking on to, like not eating a lot of breast milk, or like they're just really tiny, they know that if they get malaria, that child is very likely to die. But that this is a common piece of knowledge. What they don't know is that if they go to a facility early enough, that child actually has a chance of living. And maybe they do know that, but what they don't know is that they can afford that. They don't know that there's government programs that support children with under 5 with malaria. So often people know about the health outcomes, but they don't know about how they can treat them or what they have access to. So one of the challenges with these contexts is sometimes we're communicating the wrong thing. Sometimes people know that bleeding after birth is bad, or having high blood pressure is bad, or not going to an ultrasound is bad, or not having an ultrasound throughout the pregnancy is bad. But sometimes they say, well, I don't have the money for it, or I don't know if I can pay for it eventually, or someone else's kid got malaria and they were really small, so and they survived, so why can't my kid survive? Or another really common one among people who are on their 4th or 5th pregnancy is, oh, well, I didn't go to the doctor for my first 3 pregnancies, so why should I go this time? If they have like some lived experience. So I would say that if at these information centers, I wouldn't just focus on disease outcomes. I would also look at what programs can you advertise so that people are aware, and basically in a way that's really easy for people to share by word of mouth. So you don't want something super complicated. You want people to know, like, hey, like, if you feel like you have malaria, we guarantee that there's a program that will help you. Just come to the health facility. That way people can go in their community, they hear of someone with malaria, be like, I read somewhere that no matter your circumstance, malaria can be treated and it won't put you in debt. So I would say that. I don't know if that's a helpful answer, but I think that's a good one. And then also any like WhatsApp, that's what we use a lot of, like WhatsApp as a communication metric. So not just like posters, but things that people can really easily forward in WhatsApp communities. I think that's a really underrated digital tool. You don't have to build a new app, just use WhatsApp as much as you can.
Awesome. So I also have a question. I would like to, I don't know if you had any experience with that, but also in some rural communities, decisions are really being made, I mean, by, let's say, the husband of the wife. So if the husband doesn't think it's important for the wife to seek maternal health, they wouldn't let them go. I don't know if you have any experience with that, because even if, like, for example, if these students, they bring out the solution, creativity, they have to also consider some of the factors that prevents moms from seeking healthcare. And I would like to know if you have had any experience with that. And if so, how did you address that? Was there another education session for males, female, males, like, so that they can also influence their wife, because sometimes, as like, it can be the other way, their wife probably don't want to go, but the man will say, it's very important, for you to go. So like, I don't know if you have any sort of experience with that.
Here's the hierarchy I think is really important to keep in mind, which sometimes can be upsetting when we think about our egalitarian values of the West. I would say number 1 is religious leaders. Number 2 is elders, especially male elders, but there's even a female elders. Number 3 is males, and honestly, those might even just be the top. So the religious leaders, the elders, and the husbands and brothers, and etc. And then you have the women below that. So those are all the decision makers with power. And then you also have the person you're trying to reach, and there's this layer above them. Those 3 groups, the elders, the religious leaders, and the males, they all need different educational programs. You have to appeal to different emotions. The husbands, you want to say, hey, like, your wife is important. But sometimes that was really hard in Nigeria, where people have multiple wives. And if one wife passes away, they can just get married again. There's a little bit more of a disposability. Not necessarily, it's not necessarily like, I would say try to be mindful of judging, because that's culture. That's how society runs. Like, we're not here to rewrite the rules and regulations of society. We have to remember our North Star is supporting people to not die, right? And so you sometimes might have to appeal to cultural norms and emotions that you might not actually agree with or might not practice yourself. I think that's really important to be mindful of. But the men in the communities have such a huge role for maternal health, and you can't talk to them the same way. There's rules and customs that are very different to men and women, and that is something to respect in this journey. And then the elders as well, you, as much as you can as well with the elders and the religious leaders and the men, you have to give them power. You have to let them feel like they are the ones making the decisions, not someone else coming in saying, hey, your wife, you have to do this. Or hey, with like your members of your religious community, you have to give them option, and ultimately it's like their decision. That's what I would say on the hierarchy of stakeholders.
Awesome. But I mean, I was wondering if you had any experiences with that, and if so, like how did you approach like educating the appealing to the males to convince, or not even convince, but sometimes to even, I mean, allow their wives or moms to seek, I mean, healthcare.
I myself don't have experience in that, and part of it is because I'm a woman, and that it would kind of be the wrong a woman from the West as well. So that there's like a dynamic there. What we did is we gave that to the elders in the community and the people, like the government leaders or the leaders of the organizations. Like they were the right ones to do that. So that definitely wasn't my role, nor should it have been. So that would probably be what our approach was. We knew it was important. I helped them source the materials of what's essential. I looked at a lot of male support groups for maternal health in these communities, but definitely it's not my place to educate the men. And I think that was like really the approach we took, is we gave it to the there was a couple of people who were from Chigawa, and they were really well respected in their community. A lot of them went on to study medicine, and so there's like a level of what's the word, expertise, and or even people who went on to study law or to study engineering. Like these are people in the community who were well respected because they were educated. They might not be educated in maternal health, but when they go back and they communicate and they contribute to the community, they have a level of respect that they're the ones to go educate the men, and that's I would say is the most important. Something in the chat. The third, so it's delay in reaching care, delay in receiving adequate care, and the first one is delay in seeking care. It's called the 3 delay model.
Yeah. I would like you to tell us a little bit about the impact that you guys made through these programs. If you can elaborate more on the impact on that.
So these programs it's about making misoprostol more accessible. I haven't followed up with the government in a while, so I don't have the figures at the moment. But our initial figure was 60,000 women reached through misoprostol distribution. And when you do the math, misoprostol reduces 90% of postpartum hemorrhaging, but not everyone hemorrhages. But the point was changing attitudes and mindsets, and they did try to support traditional birth attendants and retraining them. We gave them all the curriculum. So I'd have to follow up on those exact numbers. It's also hard because it's only a couple of years, and you can't really see the impact of programs like these until it's been a decade or so. And it's also data collection was really difficult, especially in these rural communities. So we're still waiting on that. But I would say that having the materials available, and it's something that I've tried to donate to the USAID in Burundi, just sharing misoprostol resources, because we built an entire curriculum. We worked with helping babies breathe to develop that. And that's also a really great program to look at if people are interested in helping babies breathe and kangaroo care. 2 phenomenal programs that I think need to be in more places. But we worked with them to develop the misoprostol and actually worked on HIV prevention and hand sanitization as methods for women's health.
Awesome. Another question that I had is, can you talk a little bit about, I mean, how you were able to monitor and evaluate the work as it was going? I mean, the project, can you tell us more about your monitoring and evaluation process, like the key metrics that you were looking at to ensure the success of the program? Because I believe that as part of their objectives for this case study, they need to come out with some metrics that they need, I mean, like their idea or solution needs to meet, so that we can evaluate whether even that solution is working right. So can you talk a little bit more about that?
Great. This will be the second to last question. So we'll do one more after this and then I'll have to hop off. M&E is very important. I would say build a theory of change if you can. It's a framework, look at it's really great. Try to monitor your inputs and your outputs and your outcomes. These are all part of theories of change. We looked at misoprostol distributed. We looked at traditional birth attendants trained. We just looked at the components of the program. I think if you have a really solid program design, it'll be kind of obvious what metrics are important to track. I would say track less. It takes a lot of work to do data collection, and I know it might not be perfect to begin with, but when you're doing a pilot, it's really important to keep your metrics really simple. And that's one of the things I'm learning with quality improvement is when we're implementing something to a clinic that's really low capacity, you can't have too many metrics because people will then focus on what the intervention looks like rather than what the intervention does. So that's what I would say on M&E. But we so I was the director, but someone else, a really great friend, Hani Walia, she is the expert on M&E. So I'm definitely not the perfect person, but there's a lot of really great existing frameworks. And if you go to that WHO quality toolkit, there's already recommended M&E outcomes. So if you just I would recommend don't read all these documents. Like they're hundreds of pages, like they're really long, but look at the table of contents, and especially the most valuable part is the appendix. They usually have data collection forms, and that's what I would probably use as a starting point to understand M&E.
All right,
But then we'll do one more question. Okay, sure.
Yeah, definitely. I will leave. Yeah, does anyone have any last minute question? Because I think we have like 5 minutes more. So anyone have any question?
Yes, please. Hi, I have a question.
Okay, that is
Go
take
ahead.
it.
Hi. So I realized that in the rural areas, most health personnel don't like to work there because of the conditions, the living conditions, the salary they get. So most midwives and doctors, surgeons are not really in the rural areas. And I think that's a problem, because if there's an emergency, transporting a mother from the rural area to the district or the city, like, I feel like that leads to increased maternal mortality. So how do we go about that? Like, are we going to, okay, so yeah, that's my question. How are we going to increase the health personnel in the rural area so that people can get quick medical treatment or something?
That's the question that's the billion-dollar question, I would say, in rural health distribution. You have to ask yourself a couple of things. One, is there even enough personnel? One of the things that in the data that, especially that we're doing now, looking at Southern Africa, Lesotho, Eswatini, and South Africa, Burundi, Uganda, etc., is that there's a lot of brain drain. People get trained, but in the country itself, you don't have enough personnel to go around. So for example, in Burundi, there's 2 anesthesiologists. There's more than 2 hospitals. Without anesthesiologists, you can't do surgeries. And so as a result, you have informally trained anesthesiologists, and that's a problem. But then you look at who your human capital is, and you realize that there's not enough to go around. So even if you were to spread people to the rural areas, it's not enough. They're not adequately trained, and that becomes really difficult, because it's not like you can make nurses really quickly, or doctors really quickly. You have a lot of years of schooling. So I think there's a education systemic problem. So then the question becomes, what can you do with the personnel that you already have? And the question I would then ask is, what time are they wasting? So for example, that there's a lot of nurses. I mean, the reality is that a lot of primary healthcare centers, so we're not talking at the district, we're talking at the community level, don't have doctors. If they have a doctor, at least in Jigawa, in northern Nigeria, in Mugamba, in Burundi, in a lot of places, we even looked at some work in outside of Nairobi, and like a lot of these primary healthcare centers do not have doctors. So how can you have a nurse do as much as the doctor role as possible? That's a question that's important. The other question is, how much administration are they doing? Because there's a lot of paperwork burden, there's a lot of government burden, and is there a way for you to have them spend less time doing things that don't save people's lives and have them spend more time doing things that do save people's lives? That's the question I would ask for personnel, because and maybe Ghana is different. So I don't want to answer for Ghana, and that's kind of the question that your case will probably explore. Can you bring personnel into these communities? If you increase their salaries, will they stay? Or if they get a job offer in Canada, will they just go to Canada? Because ultimately, that's a really big problem. The brain drain that happens between these really great healthcare workers that could do amazing things in their home country, but they have an opportunity elsewhere. Or even if they go to the big cities or the more like district hospitals, do they have better working conditions? Are they easier to work with? That kind of thing. And then referrals is also critical. For us, we really struggled with referrals because we didn't have good phone lines. If you don't have good phone lines, you can't call the district hospital. You can't just send an ambulance. I don't think Ghana has this problem. We even have a problem with gas. So in Burundi, you have to wait 5 days to get gas. So if you don't have gas and you have someone you have to refer, you can't actually send them to the hospital, and that becomes a problem too. So what we thought about is, how can you call a doctor so that if there's a situation that you can't refer for a couple of days because you're waiting on gas, can you get an expert to call in so that maybe there's something you can do better given the constraints that you're in? So that's maybe one thing I would think about is there a way to not have doctors physically be in these locations, but still contribute to these locations? Another solution that the clinic that we were like the company that I was working for was funding in Burundi is they have a part-time doctor. So they have one full-time doctor who's the medical director, and they have a part-time doctor. And that part-time doctor comes 2 or 3 times a week, which relieves a lot of the burden. And one of the things that I think is interesting with having a medical director that's also a doctor, which is like best practice, one of the things that becomes challenging, I said interesting, but I think more so challenging, is that they're only doctors some days of the week, also has to do a lot of paperwork for the government, etc. And so that's where I think that there's a new role for administrative healthcare workers, so that the nurses and doctors can do medicine, where someone else can be doing the paperwork, the government meetings, etc. That becomes hard though when you have someone who might not be medically trained to be talking with government officials about very medically critical things. So that would be one challenge that I'm seeing at the clinic, which could be interesting for you to think about. So just to summarize a couple of key points. One, look at how you can reduce the burdens of what the existing personnel are doing. See if you can phone in experts. See if you can work at the incentives. So can you try to redistribute resources so that people actually have good jobs in these rural communities? How hard is that? And then how can you educate people? And then also I would look at community healthcare workers. I think community health extension workers are the basis of the healthcare system in most parts of the world, and they play such an important role. Like, I cannot emphasize enough. And if you can look at, so CHEW, that's the acronym, but also maybe CCHW, if you can look at any existing programs, and if I'm remembering correctly, Zambia has a good amount of them funded by the UNFPA, and I think that's a really interesting resource to look at. How do these people distribute? There's another program in Uganda called Healthy Entrepreneurs, and they similarly create a training program to distribute female workers in communities to also build trust. So there's a lot of really interesting examples of community health extension workers, and they can support nurses in rural communities. So the nurses don't have to go out into the community. So a lot of rural healthcare work is community-based, and you don't need to be a trained nurse to be able to, share information. So that's maybe some things for you, Gladys. Yeah. I will have to hop off now, but I'll say, let me know if there's anything else that I can.
Yeah, definitely. And once again, thank you so much for sharing this nuggets with us. Definitely, these are very important. I believe that it would help our case participants as they prepare. For their case competition. I know it's exactly a week from today. So thank you so much for coming now to share that with us. Definitely, if anyone do have any questions, I would compile that in an email and send that over to you, and then maybe you can answer that for us. But once again, thank you so much, for making it to the meeting today. And really, really appreciate it. And I know that you have to run, so have a wonderful rest of your day. Yeah.
You too.